natriuretic peptide, it's going to be indicative of heart failure to some extent. Okay? Now we're going to go into our meds. My favorite part. Fuck you if you think I'm cheesy. I don't give a fuck. We have ACE inhibitors, we have beta blockers, we have calcium channel blockers, we have positive inotropic drugs. ACE inhibitors. Basic mechanism of ACE inhibitors. They're cool. What they do is that they inhibit the conversion of angiotensin 1 to angiotensin 2, which prohibits angiotensin 2 to excrete this potent chemical called aldosterin, which actually causes vasoconstriction to increase our blood pressure. It is a natural defense mechanism in our body. You guys know how it works, but when there is complications, it's actually going to cause more problems than any good. So we inhibit that process by using angiotensin converting enzymes. So what is it going to do? What are the symptoms? What are we looking at? ACE inhibitors have a tendency to increase your potassium. They might have a rash. That's a sign and symptom you want to look for. Specifically, angioedema we talked about. Angioedema is the swelling of the face, lips, all that other extra shit. Kudos to Ali Wood in her class who texted me yesterday and said the way I'm going to remember that is ACE fucks your face. Angioedema. That's okay, we're students. So anyway, cough. Cough you're going to see in 20% of people who are on ACE inhibitors. Specifically, the medication is lisinopril. And that's another thing about your ACE inhibitors. Your ACE inhibitors are usually all prils. Your medications will all end in prils. It has a tendency to lower your blood pressure, which ideally is the therapeutic goal. We want to reduce those from a hypertensive standpoint, where we're using it for that. Angioedema we talked about, and in pregnancy it tends to injure the fetus, so it's definitely contraindicated. I'm assuming then that ACE inhibitors might be a Schedule X for teratogenic drugs? Teratogenic drugs? Alrighty, anyway, moving along. Beta blockers. Beta blockers are cool. Beta blockers are actually two steps. They do mess with the beta 1 cells and the beta 2 cells. Beta 1 cells are pulmonary related and beta 2 cells are cardiac related. These are your LOLs. Metoprolol, propranolol, timolol, etc. Classic sign and symptom is your bradycardia. It's going to decrease that heart rate. Usually you'll see parameters. I know most of us are LPNs. You know, we do see parameters in the nursing homes that say if a person's pressure is systolically less than 100, you know, and so forth. So, I mean, in a working standpoint, you're going to see it often. Orthostatic hypotension. These are classic symptoms that allow us the opportunity to teach our patients. You know, when we want them to get up, we want them to dangle at the bedside first so that they don't have that sudden rush of a fluid change when they're getting up and things like that. So, orthostatic hypotension. We have mental depression. We have impotence. We have bronchospasms. This is why beta blockers, in particularly, are contraindicated in use with patients who have COPD and patients who have asthma. Right. So, thankfully, we do get by this because we have cardioselective beta blockers, aka selective beta blockers, that actually can be used if you have those problems. Specifically, the two that can be used are metoprolol and atenolol. And then the other problem with beta blockers is that it masks the signs and symptoms of hypoglycemia. So it can have an effect on people who are experiencing a hypoglycemic reaction or having some type of induced hypoglycemia. You know what I mean? They'll probably be reading normal on your Accuchecks. Hallucinations is a big problem. You're going to have impaired peripheral circulation, shortness of breath, Raynaud's phenomenon. These are the ones I'm getting from this actual PowerPoint. What I did is I included the med study sheets and incorporated them with the heart failure PowerPoint suggested symptoms. These in particular were the ones that were added. Insomnia is one, sexual dysfunction, and you're also going to see an increase in triglycerides. I don't know how I feel about beta blockers now in light of all those symptoms. You know, bad sex, bad cholesterol. I don't know if I want that. Then we have calcium channel blockers. Very important though, before I talk about what calcium channel blockers and beta blockers do, these two have three important functions, and they're right here. Calcium channel blockers and beta blockers decrease your contractility, they decrease your heart rate, and they decrease your blood pressure. So that's why they're multifunctional drugs. They're good for heart failure. They're good for as antihypertensives and all that stuff. Okay, so calcium channel blockers. What do calcium channel blockers do? They basically inhibit the binding of calcium to those cells, and as a result, they prevent vasospasms. Calcium channel blockers have two classifications. There are non-hydropyridines and dihydropyridines. Your non-hydropyridines are your pines. All the drugs are going to end in P-I-N-E-S. And the only two that we discuss in class that are non-hydropyridines are diltiazem and verapamil. These are the two that we specifically would treat a patient who has sinus ventricular tachycardia. And then the side effects are in your PowerPoint for those. I mean, I know one classic one is headaches. Same thing with nitrates, headaches. Your positive inotropic drugs. These drugs are cool. You have three classifications that we're discussing in class. We're discussing the glycosides, which is digoxin. It's a derivative of a plant extract called digitalis. Those are used specifically for things like AFib, aflutter, and systolic heart failure. Then you have PDE inhibitors. You have Inocor and Primocor. And then you have catecholamines, such as dobutamine and dopamine. Those are all real good things to increase contractility. That's what positive inotropics do. They increase the contractility, and and you know that's a good drug because it's one of our goals in treatment for heart failure. So then we have the DIG signs and symptoms for toxicity. DIG is a very weird drug. I don't remember the levels, but I know they're very narrow, like a 0.5 or 1.25, like that's the extreme their goal. But it's such a narrow therapeutic index that the likelihood of toxicity is probable. So you want to be very careful in assessing a patient. Number one, before administering this drug, you know what we have to do. We have to assess the apical heart rate. Typically, parameters will include to hold the medication if it's less than 60 apical heart rate. Number one symptom that you're going to see in a patient who may become DIG tox is nausea and vomiting. Very good indicator. You want to stop the med. Call your physician, let him know, hey, John Doe is experiencing some nausea and vomiting. He is on DIG. I recommend we get a DIG level to assess, although a patient should be having DIG levels regularly if they're on the medication in light of its narrow therapeutic index. Then the green halo, that's a result of vision changes. You'll see the green halo in your vision. You'll also see monitoring of potassium levels because it tends to be more toxic and cause hypokalemia. And that's that for your meds. It's very simple, not too hard to digest, I think. I find that I'm a good bullshitter, so I can talk my way through it. Then we talk about acute heart failure. Acute heart failure, one of the examples that was used in our PowerPoint is pulmonary edema. What happens is that fluid is going to back up into the lungs. In the attempt of gas exchange, you're going to have the fluid now involved, and the fluid and the air and all that stuff coming up is going to cause hemoptysis. Otherwise, that classic pink-tinged sputum that's frothy, that's a classic symptom. At the end, the result is going to be the patient's going to become hypoxemic, basically. Hypoxemia is going to result. So definitely the position for that patient is high Fowler's. We want to supplement the patient with O2. And you might also need to use inotropic drugs such as dobutamine, Inocor, Primocor, and you may also need morphine sulfate. The reason we're using morphine is because this patient is more than likely going to experience some type of discomfort, pain. We want to use that. They may be a little distressed too. You think about it, morphine is a narcotic. It's going to decrease respirations. It may ease the patient's anxiety level and as a result reduce the tachycardia, which results in decreasing the workload of the heart. So it has a lot of functions. But the primary functions, not to get it off in a tangent like my friend Mr. Honeywell, I do like you, you're a great teacher, is pain management. But then the secondary use is the vasodilatation, and that's what we want to use it for as well. And I told you about the PDAs. And that concludes the PowerPoint. Hopefully I condensed it, and hopefully I didn't speak too fast. Thanks.